Hi, everyone. Welcome to our Thursday webinar series. My name is Lourdes. We're glad to have you on the call today. As a reminder to everyone in the community who's watching, please, if you have questions, enter them into the chat or the Q&A button that you can find on your Zoom. And please try to make your questions in general in nature. Our speaker is not able to answer specific medical questions that you might have. And with that, I want to introduce Dr. Abdelrahim. He is a gastrointestinal medical oncologist and transplant oncologist, where he is taking care of patients with upper and lower GI malignancies, in addition to malignancies treated by liver transplantation. He is the section chief of GI medical oncology, leading the GI cancer care at Houston Methodist Neal Cancer Center, with the focus on clinical trial phase 2 and 3 in GI malignancies. Dr. Abdelrahim serves as the medical director of Cockrell Center for Advanced Therapeutics, where he oversees phase 1 program at Houston Methodist Hospital and Neal Cancer Center. He is a principal investigator on multiple clinical trials with focus on chemotherapy, targeted therapy, and immunotherapy in GI malignancies. His translational research is focused on developing new mechanism-based drugs for the treatment of gastrointestinal cancers. He has published more than 130 research articles, review articles, and book chapters in prestigious journals and publishing groups. We're so glad to have you here today. Thank you.
Good afternoon, everyone, and thank you for joining us. And thank you for the Cholangiocarcinoma Foundation for having me and for arranging this series of webinars, educational for our patient and oncology community. So today we're going to discuss in the 30-minute advancement in cholangiocarcinoma management, what's in use. Basically, we're going to have a focus on two aspects in the management of cholangiocarcinoma, and the medical management and the surgical management. So it's a devastating cancer, and we all know this is a fact. Out of GI cancer I treat, cholangiocarcinoma and pancreatic cancer are the two diseases that we have a challenge to have a good outcome. It's the second most common primary hepatic malignancy, and the median survival is around 12 months, 5-year survival around 10%. It's not one disease based on anatomy of the cancer. It can be intrahepatic cholangiocarcinoma or extrahepatic, and the extrahepatic can be subdivided into proximal or distal, in addition to the gallbladder cancer. Globally, there have been a rising in the incidence of cholangiocarcinoma, and in United States, it's been more than double over the last few decades. And the question why this is the case, we don't know. We know there is a risk factor might be associated with cholangiocarcinoma, including obesity, metabolic syndrome, chronic inflammation like Hep B and C, liver flukes, like which is in certain area of in China, primary sclerosing cholangitis, inflammatory bowel disease, cyst or stone of the bile duct. However, more than half of the cases with cholangiocarcinoma present without a known risk factors. So it's not clearly known what causes cholangiocarcinoma. Risk factor associated, but it's not direct causal for most cases. Globally, the mortality rate vary, and as you can see by a color-coded map here, the high mortality, which is more than 2 cases per 100,000 population, considered high mortality compared to low mortality, which is less than 1 case per 100,000. And as you can see, United States is the moderate with the green color there, and the dark color in the Europe. You can see it in UK, Ireland, and in Asia, and South Korea, and Japan, and Hong Kong. The prognosis is poor, and the intrahepatic and extrahepatic cholangiocarcinoma, regardless of the stage, you see the 5-year survival is low, and also including gallbladder cancer. And actually, it's worst when we have an advanced disease, like a distant metastasis. You know, even though like a localized disease with surgical management might have a better outcome, but even though those still have a recurrence of the disease, and there is a poor outcome. So we need to do a better job and identify a better medication and better treatment and better regimen. For ages, we treat cholangiocarcinoma by chemotherapy. And for 85% of the patient, we treat them with gemcitabine-based treatment, GemCis or others. 46% of the patient will make it to the second line, and this is mainly based on 5FU. Two patients make it to the third line, around 17%, which is a mixed bag of different therapy, and we will discuss in the next few slides. This is CCA guideline for this year, 2025. And as you can see, for the primary and preferred regimen, it is chemotherapy based. And this is a combination, but the backbone is really chemotherapy. As you can see from the slide, chemotherapy for advanced disease have very slow progression. Back in 2010, based on the ABC-02 trials, gemcitabine and cisplatin become the standard of care. Since then until now, Gem-Cis has been the backbone for most combination. And as you can see in the second line setting, based on the ABC-06 trial, FOLFOX become the preferred treatment. There's a nifty trial that showed 5FU and the treatment or lebrikizumab can be in the second line setting as well. And even with the new treatment, just last year, 2022 and 2023, as you can see, immunotherapy have been added to the backbone gemcitabine and cisplatin, like a TOPAZ-1 trial with DOPA been added to Gem-Cis, and the Pembro added to Gem-Cis based on the Keynote 966. So bottom line, the chemotherapy wouldn't have much success for the last 15 years or so. It's basically Gem-Cis or 5FU treatment. For the second line option. We live in the era of precision oncology and precision medicine, and cholangiocarcinoma is part of this revolution. And as you can see, there's multiple actionable mutation that have been found in cholangiocarcinoma. And actually, more than 50% of the cases of cholangiocarcinoma have an actionable mutation. And as you can see here on the graph, IDH1 and FGFR2, HER2, BRAF, and others are one or some of the actionable mutation or alteration that we see in cholangiocarcinoma. They are occurring in different percentage. Nonetheless, we should look for those because we have targeted therapy for that. So targeted therapy for cholangiocarcinoma actually have a rapid progress. Even though initially we have a negative trial by adding targeted therapy like EGFR inhibitor to chemotherapy showed no benefit, and even VEGF and VEGF receptors, when we added to the chemotherapy backbone, there was not much of a benefit. However, later on, we found that is specific targeted therapy for IDH1, FGFR2 fusion or alteration have shown increase in the survival and outcome in general, overall survival, progression-free survival, and duration of response. So this is promising, and this is open the door of targeted therapy in cholangiocarcinoma. So we should always look for actionable mutation for all our patients when they come in with a cholangiocarcinoma diagnosis. We should do that from the get-go, from the time of diagnosis, and this can be repeated later on, depending on the time of diagnosis and what type of treatment and line of treatment. This is the guideline, as you see, the NCCN guideline showing that targeted therapy is useful in certain circumstances. Obviously, when you have the mutation or you have alteration, then you have a drug that can target this mutation. And one of those, one of the important target actually is HER2 positive tumors. And as you can see, which is highlighted in red there, HER2 positive cholangiocarcinoma have multiple options. For example, trastuzumab deruxtecan, trastuzumab, pertuzumab, tucatinib, and trastuzumab, and zani. Those are antibody drug conjugate, monoclonal antibody, TKI, or bispecific. So different mechanism of action targeted in HER2 as an attractive approach to treat cholangiocarcinoma. But can we treat HER2 positive cancer with cellular therapy? Cellular therapy, as you know, and adaptive cellular therapy have shown promises in treating certain solid tumors, including melanoma and cervical cancer, with more than 50% clinical response and limited off-tumor toxicity. Basically, you isolate TIL, which is a tumor-infiltrating lymphocyte, you expand them and infuse them back to the same patient and hoping to have more immunogenic response and getting more control of the cancer by designing or at least extracting and expanding patient tumor-infiltrating lymphocyte. Another way is T-cell receptor cell therapy or chimeric antigen receptor therapy or CAR T-cell. Regardless what it is, here you're using engineered T-cell to target cancer. In our institution, we have developed HER2 CAR T-cell, and this have shown actually to be having a good cytotoxic response to cholangiocarcinoma cells in vitro. What you can see in the top panel, basically, is a flow cytometry. We're showing that these cholangiocarcinoma cells express HER2. And in the lower panel of the graph, you see HER2 CAR T-cell construct. And below it, in D, you can see there is a flow cytometry for CAR expression on the T-cell for HER2. What you see in the panel E and F is actually cholangiocarcinoma cell treated with HER2 CAR T-cell, which is shown in red. And you see the percentage of killing, which is significantly higher compared to the cells that have been treated with a control T-cell. So that's a positive, encouraging data. And definitely we took it to the next level because we know this is a cell line in a petri dish. We can't conclude based on that. We took it to the animal study, and we did a xenograft model where basically we inject cholangiocarcinoma cells in the under the skin of the mouse, and we treat then we wait around 3 weeks. We treat with CAR T cells, and we evaluate for tumor growth and response. As you can see in B and C in red, these mice treated with HER2 CAR T cell, and there's a significant tumor suppression compared to the mice treated with control T cell, which is shown in black in B. And when we look at the survival curve in D, you see that is HER2 CAR T cell mice treated with this construct or actually T cell have significant improved survival compared to the mice treated with control T cell, which is shown in the black. So we took it to the next level from xenograft model to the orthotopic model for cholangiocarcinoma. Basically, we inject cholangiocarcinoma cells to where they belong, into the liver, into the bile duct. We waited 5 days, then we treat these mice with CAR T cell intravenously. If you look at the curve and C and look at the figures in B, you will see that mice treated with HER2 CAR T cell are actually having significant survival improvement. And you can see the tumor activity, as you can see in the right panel, in these mice, which is shown yellow and red, actually disappearing and disappeared by day 11, compared to the mice treated with a controlled T cell in the left panel, and the tumor continued to grow and end up, killing these mice. So CAR T cell is not without challenges. There are some challenges of tumor heterogeneity and antigen escape, CAR T cell trafficking and infiltration, make sure these CAR T cells actually reach the tumor, and also in the immunosuppressive and nutrient-restricted tumor microenvironment. These are challenges for CAR T cell. In addition, there's some toxicity. There's nothing without toxicity and from when we treat cancer. So there's some toxicity, and we try to do a better job when you use CAR T cell and improve them. So what we did in our institution is that we produce hypoxia-responsive CAR T cell. Basically, this is, as you can see in the construct or the vector on the left side, these constructs have what we call oxygen degradation domain, in addition to the hypoxia response element. Basically, what you see on the right side figure is that when you use these T cells, in a normoxic tissue, which is a normal tissue, the CAR engine shut down. Basically, you don't produce activity. And in the hypoxic condition, which is usually the tumor have a hypoxic condition, low oxygen, increased hypoxia markers, the CAR engine is on. Basically, the CAR cells work. And this is a design in a way to reduce the off-tumor toxicity as well as increase the maximum tolerated dose. Basically, the second generation CAR T cell with a better, targeted to the tumor and less target onto the normal tissue in the hope to decrease toxicity and maximize response. So we tested this CAR T cell, and this is the flow cytometry, as you can see. What you see in this flow cytometry at a different concentration of oxygen, 20%, 1%, and 20% back. What you see in the box, inside the box, is the expression of CAR in this situation. So in an anoxic condition, 20% oxygen, there's no expression of CAR in these T cells. But in hypoxic condition, 1% oxygen, you see that box is filled of these cells. There's more expression of CAR. And when you put it back on the normoxic condition, the expression goes down. So basically, this is a good model, a good ideal construct where you can turn on and off CAR T cell based on the location, tumor versus normal tissue. And when you look at the C, this is the percent killing of cholangiocarcinoma cells treated with CAR T cell of hypoxic CAR T cell, basically the specific one, in two conditions. In red, when it is hypoxic and you see more killing, and in black or white circles, which is non-noxic condition, 20% oxygen. So you can see that killing of cancer cell is conditional based on the hypoxia of the tumor, which is a neat pathway to selectively kill tumor cells but save the normal cells. And what you can see also here in the model, this is an orthotopic model again, the one we used before, and we use it here for hypoxia CAR T cell. We call it CAR ODD T cell, which is the same name. What you can see here, that is like cholangiocarcinoma cells, HUCC was injected into the liver. 3 days later, CAR T cells, the specific for hypoxia, then injected into the IV of these mice. And we looked at the survival of these mice. What you can see and see, that's the survival curve, which is showing that is the survival of mice treated with hypoxia HER2 CAR T cell are actually significantly improved compared to those mice treated with a CAR T or control T cell. And if you look at the figures on the right, you can, without looking at the curves, you can see the obvious response of hypoxia HER2 CAR T cell. So this is proof of concept that is, yes, hypoxia HER2 CAR T cell actually can decrease or inhibit growth of cholangiocarcinoma in the orthotopic model compared to the control T cell, which is showing significant progression of cancer and in the taking the life of these mice. So ongoing, or actually in preparation, phase 1 trial for CAR T cell therapy is targeting HER2 is basically planned and prepared. Protocol is written actually in our institution, and hopefully in the next few months we'll get the ball rolling for these trials. But still, it's phase 1, and there's we still have going through regulatory component of it at this moment. Nonetheless, it's really a promising concept, and we hope to open the trial soon. The question here is, can we use CAR T cell to bridge cholangiocarcinoma treatment to liver transplantation? The answer, we don't know. This is too soon to even think about, because we need to use it first in the normal situation. Then we can think about using CAR T cell to bridge to transplantation, taking the risk of rejection and all that. But I use this question or challenging question to my leeway to my next part of the presentation, which is treating cholangiocarcinoma by transplantation. As you remember, in 1990, initial attempt of liver transplant for unresectable high-like cholangiocarcinoma will show unacceptable outcome. 5-year survival, 23%, and most of those patients have a recurrence within 2 years. But that's because you work on solo. When the surgeon work with the oncologist and they both produce an ideal setting condition, the outcome can change. And in this situation, when they use chemo and radiation therapy, the 5-year survival become 80%, favoring patients with primary sclerosing cholangitis. And this is speaking for the role of transplant oncologist. So and this become a standard of care. What about intrahepatic cholangiocarcinoma? Surgery by itself produces 5-year survival of around 45%. Local therapy produces 5-year survival of 16%. Radiation can do it up to 70%. Systemic therapy is only 25% in the 2-year survival. And initial study in the 80s and the 2000 for liver transplantation for intrahepatic cholangiocarcinoma has been contraindicated based on the poor outcome. And actually, this study was criticized because the small size, it's a mixed bag. We don't know what's intrahepatic or extrahepatic, and it includes both cirrhotic and non-cirrhotic. So the data was not clean and couldn't conclude anything out of these early studies. However, a newer study, meaning that is the study after those early studies in the 2000, 2016, there's a multi-center study or retrospective have shown actually liver transplant for early intrahepatic cholangiocarcinoma that's small, less than 2 centimeters, in cirrhotic patient can have a good 5-year overall survival of 65% and recurrence rate is low of 18%. In our institution, we also publish our experience on a patient with local advanced non-cirrhotic who have treatment with chemotherapy and showed disease stability for more than 6 months. We showed that is the 1-year survival is around 100%, 3-year survival around 70%, and 5-year survival in the 50s, which is significantly way better than treating those patients with chemotherapy. And we know that is the median survival for those patients is around 11 months to 16 months, depending on the type of treatment. So yeah, for well-selected patient with intrahepatic cholangiocarcinoma, liver transplantation is curative with superior outcome compared to surgery or systemic therapy. How we select their patient? Is it based on the disease burden, size or number, or biology of the disease and response to treatment, basically stability of the disease? Well, now there's no clear guideline on the type of new adjuvant or bridging therapy, but the improved 5-year survival with the new adjuvant and adjuvant therapy is actually evident and independent of the tumor size. We publish our experience actually, and we have shown that is gemcitabine and cisplatin-based treatment behave and do a better job than non-gemcitabine-based treatment. And we show that is the 1 and 2 year survival is around 100%, and also for that 3 and 5 years, 75%, which is better than others. So the recurrence of disease also was delayed and was taken down. So the question is that, we increase our transplant for cancer indication, and there's many reasons to do transplant to treat cancer, which include liver cancer, neuroendocrine tumor, and that's appropriate. But can we do the same for intrahepatic cholangiocarcinoma? We have to take this in consideration. Is it the right decision to do for the patient, increasing survival benefit, and for the transplant community, given the limited number of organs? And actually, the data now is supporting that. It's supporting that is intrahepatic cholangiocarcinoma can be a good indication, and patient can benefit from the transplantation. And this might be a good utilization of organ to treat those patients. As you can see, like I don't want to go in details, but there was multiple reports, including from our center, have shown that actually the 5-year survival for transplantation for intrahepatic cholangiocarcinoma is roughly in the 50 to 60%, which is, as we discussed before, this is way better than chemotherapy alone. So literally, you can increase the survival of those patients by transplantation. And the selection criteria is varied, but in general, for a well-selected patient population, the transplantation can be a curative treatment for some. This is our protocol or Methodist MD Anderson selection criteria. I'm going to go in details, but we put this criteria after significant discussion among the transplant surgeon, the pathologist, the oncologist, and we get together, we put this criteria based on our experience. We have been having a good outcome, which is, I think, similar to the criteria in other centers. It's not for everybody, but for selected patient population, it can be a good options. We participated last year on International Liver Transplant Society consensus conference, which was in Valencia, Spain, in February of last year, where we got it together with experts across the globe to see how we can suggest some guideline to improve the outcome of cholangiocarcinoma by transplantation. And we came in with some recommendation, and this recommendation actually was published and was taken into consideration. And there was different society did the same, so that you can see the number of society interested in this topic is large, and there is a need for it because it is a hot topic. For example, AASLD, their recommendation is that liver transplantation for
intrahepatic cholangiocarcinoma and that's unresectable can be considered under research protocol. So they've been conservative. However, International Liver Transplant Society and ILCA, they came with a recommendation that for cirrhotic patient, you can consider it. And for a non-cirrhotic patient, you can have it best in the protocol. So the society have some opinion about that, but I think the more data is coming and supporting that is transplant can be a curative treatment for selected patient population for intrahepatic cholangiocarcinoma. And this is part of transplant oncology. We had the pleasure of publishing the first transplant oncology book actually globally. There's 26 chapters in this book and written by experts across the globe, in United States, North America, South America, Europe, Asia, Middle East. So we had experts writing chapters on transplant oncology, discussing different topics, including transplantation for cancers, not only cholangiocarcinoma, but even other indications. So I encourage you to take a look on this book and consider it as educational reference and source for your society, and because it's really discuss important topics, including the one we're discussing today. So in conclusion, systemic chemotherapy is the oldest treatment option. However, it's still the standard of care and the backbone for future combination. Targeted therapy is rapidly progressing as an attractive new treatment options. However, resistance can be an issue. Serial therapy is a promising option when the above fail. This is under investigation, but I think the data is suggesting that direction. Hopefully in the future, we can offer our patient not only systemic chemotherapy, not only targeted therapy or immunotherapy, but we can offer them immunotherapy by cellular therapy. And liver transplantation is a curative when a cure is feasible goal. And finally, transplant oncology is an evolving field in cancer that hosts all of the above. I would like to thank my colleague. This is a team effort, and like Dr. Lula and Dr. Ismail and all our colleagues who are in the photo or in the names, but there's many people participate, our transplant center, our cancer center, and our colleague who participated on most of this study. And we would like to thank our patient and their loved one and their family for their support. The medication that we enjoy today to offer to our patient are actually a success of our previous patient who participate in clinical trials. So clinical trials not only benefit you directly, a cancer patient, but also benefit maybe a family member, a friend, or a future patient. So the clinical trial participation is the way to go to defeat this cancer. With that, I'll be happy to take questions. Thank you for your attention.
Thank you so much. I do have a clarifying question to start. I think on one of your initials, in one of your initial slides, it had IDH1. There was a bullet point there, and they were just trying to clarify what it said after ivosidenib. I don't know if you can go back to that initial slide.
So you're talking about the clarity, this slide?
Where it says they put under here, it was a bullet point that wasn't quite readable, and it had ivosidenib.
Yeah, this is the one?
Maybe.
Yeah, I tend to give like the big pictures without going specifically in the details. But in general, let's go back. For example, like this is the study where ivosidenib is improved progression-free survival, and patient will have IDH1 mutation cholangiocarcinoma second line and later line of therapy. So those the trial initially, most of the target therapy initially, they required patient to receive chemotherapy as a first line, and those who progress on the second line and beyond, target therapy was offered for those patients. That's because we need to offer them the maximum benefit, which so far been through the chemotherapy, but later on at that time, targeted therapy was under investigation. So that's why you find this trial designed in a way that patients receive the maximum benefit from chemotherapy, then offer them a targeted therapy. Because sometimes the cancer is driven by this mutation, so targeted therapy can be the answer, and patients sometimes have maybe a better outcome even compared to chemo. But this is where the targeted therapy is coming now.
Great, thank you. Are CAR T cells able to be used in all stages of the disease?
Because if it's under investigation, usually we don't offer it. We don't offer investigation drug when we have a standard of care is proven and to give a good outcome and increase survival. So you find that most of the CAR T cell, and at least the one we design, is offering it after patients who are refractory to the first line or second line standard chemotherapy. So if you should be on chemotherapy initially and targeted therapy if you have targeted therapy, and those can be offered after that and should be offered based on your molecular profiling. For example, in this case, a HER2 positive serial therapy for patient or CAR T cell, HER2 CAR T cell should be for patient who have HER2 positive who was treated previously by FDA approved medication, which is listed in front of you here.
Okay, perfect. Does CAR T cell therapy then increase the risk of liver transplant failure?
Yeah, this is $1 million question. And actually, I put that question there because as investigational and as far as what to think about, we just like these conferences and this discussion is actually brainstorming what next we can do, how we can challenge ourselves. And we ask question. Initially, this is a topic of interest to me personally. Initially, there's an interest of immunotherapy to treat cholangiocarcinoma in chemotherapy and targeted therapy and immunotherapy rather. And for HCC, which is immunotherapy, become a backbone on the preferred first line treatment. So the question, can we use this medication with immunotherapy to bridge patient to transplantation while we're waiting for the organ? Can the patient be treated with immunotherapy-based treatment to have a better control of the disease, shrink the cancer while waiting for a liver? That was like a big question, and we published our data and actually our prospective clinical trial using atezolizumab on before transplant for HCC rather, not for cholangiocarcinoma, but I'm using it as an example. But the question is now we have immunotherapy in the first line setting and getting us a better job than chemotherapy alone. Can we utilize this before transplantation? Yeah, and actually, our most experience is coming from liver cancer, not cholangiocarcinoma, because HCC have a more immunotherapy approved in the first line setting and even second line setting before cholangio. So our experience comes from liver transplantation after patient been treated with immunotherapy-based bridging therapy to transplantation. And the data is evolving, and I will not say this is standard of care, but we publish it, and others did publish as well, using immunotherapy before transplantation, as long as there is an appropriate washout period, as long as the patient been managed appropriately before transplantation and after transplantation with appropriate immunosuppressant. So for immunotherapy, yes, we have data. For CAR T cell, I think it's so premature. Let's first use CAR T cell to treat advanced stage. Then once we succeed in that, we can think how we can bridge transplantation and how we can use it as a new adjuvant therapy or bridging therapy to transplantation, basically to cure cancer.
Okay. At what interval do you suggest that cholangiocarcinoma patients be tested to see if they have any new markers that have become available as targeted or a trial or adjunctive therapy in their treatment regimen?
It's the guideline, actually. Like all patients who have cholangiocarcinoma diagnosis, and most of the cases, other even solid cancer diagnosis, who are in advanced stage, when they have a piece of tissue, that piece of tissue should be sent out for molecular profiling, because that will open multiple doors. As you see, on the previous, there is multiple targeted therapy, but it depends on the percentage of this mutation or alteration in the cholangiocarcinoma. But the recommendation is really to send for molecular profiling. And even if the tissue is not available, the liquid biopsy from blood sample can be sent. Not only at the diagnosis, and if the patient has been treated with multiple line treatment, you can actually retest again to see if clonality of the cells or the cell population change that might have a better target now that you didn't have it before. So the time is right, and it's been multiple line treatment, and it's been a long time. I think retesting can be a good idea. It might open a door for you.
Okay, perfect. Is liver transplant with spread to regional lymph nodes possible?
Usually the guideline or the recommendation of most protocol or institutional protocol, they exclude patients who have evidence of extrahepatic disease. And once the cancer is outside the liver, in a lymph node or elsewhere, this usually exclusion criteria that for transplantation, because this is a major surgery and you take an organ and as a life gift from somebody or living donors, you after going through this process and procedure and transplant, if the cancer is outside the liver, it can come back. And it's going to come back in a situation that is you're already having a major surgery and you're already an immunosuppression, and now you have the cancer come back. So I think the outcome usually poor. So we tend to make sure that is using all the imaging modalities and testing modality that patient before go to transplantation that they have liver-only disease. If there's suspicious lymph node, which can be seen because some of those patients have cirrhosis and some of these lymph nodes can be reactive. If that's suspicious, don't assume, just biopsy it and make sure it is not reactive. If it's reactive, you can continue to monitor and continue to be a transplant evaluation and maybe listed. But it's need to be excluded because transplant should only for patients who have liver-only disease. No lymphatic or extended or distant organ metastasis.
Can you expand a little bit on maintenance capecitabine? Has this been shown to help prevent recurrence after transplant?
After transplantation, actually, we take a look on the pathology. So there is certain markers that we think this is a red flag that's for cancer recurrence. So each institution is a practice, and I would like to maybe this is a good question for your treating oncologist, but in general, and my practice, after the explanted liver come out and we take a look, and if we have really risk factors, and most cases, there is usually like multifocality, viable tumors, if it's having to have a lymph node for sure, if it's close to the capsule, or if it is the cancer is like really have how to say it, maybe lymphovascular invasion, perineural invasion, all these like histopathological features raise a red flag that is the cancer recurrence might be imminent and that can be soon. So it's good to clean after that, and and it's practice to practice different. And I myself, Xeloda might be an option, but I tend to, if the patient been on gemcitabine and cisplatin before transplantation and the response been good, I tend to keep gemcitabine and cisplatin because patient already responding, and we know that the cancer is responding to gemcis, so I tend not to change. But in general, it's good to clean up after the fact. It's a major surgery, and the spill and all that. It's always good after being in this major surgery, and if you have these, to consider adjuvant therapy. However, if this cancer, for example, for whatever treatment you treat, and this is it is T0 and 0, and there's like no cancer was seen in the explanted liver, which is, sometimes we saw it, and I saw it in a couple of my patients not far away. In those cases, if the cancer is totally gone, T0 basically, and there's an N0, what are you treating? We didn't have enough data to say like, no, you should not treat or you treat, but common sense and common thing being common, if all treated and all gone before transplanted, before transplant the patient, what you're treating. There's no evidence of cancer in the explanted liver. So it's individualized decision. And I would say like, no, there's no right from wrong answer. And it's depend on the treating oncologist. In my opinion, if the cancer is gone and T0 and 0, and I don't see a reason to, add chemotherapy to a patient who's been through a major surgery and usually been through a line or two before surgery with chemo or targeted therapy. So as I said, this is individualized question, individualized case by case, and it's based on the treating oncologist.
Thank you. Can a liver transplant be an option for intrahepatic cholangiocarcinoma for recurrence?
That's a good question. If the recurrence is localized in the liver, and actually this is going to be an institutional question. The recurrence, usually, like if it's recurred in the liver, does it have a risk of recurring outside? It's really like, I would not say like, yeah, you definitely jump into it and there's a retransplant, but this is somebody we treat and to prove that there's nothing outside. And this is based on the transplant center and to reconsider for a second liver. But, it's case by case, and, because these organs are actually, the transplant list is really crowded, and like we have to make the right decision, and we can be considered. I will not say no, but it's also based on the protocol for each institution.
A few people are asking if your slides would be available afterwards. If they are, great. If not, just let us know, and then we can, if they are, we will make sure to share with the community. But I will double check with you if that's okay. I know there's some information on there.
We can follow up on that because some data is not published. So and it's a colleague data also. So it's maybe not all of it, but we'll happy to share some.
Yes. Can a cholangiocarcinoma patient with pre-existing primary sclerosing cholangitis get radiation therapy? I don't know if you can answer that.
So cholangiocarcinoma in the setting of primary sclerosing cholangitis, can they get radiation?
Yes.
Is that a question?
Yes.
Yeah, I didn't see like an objection for radiation in the setting of primary, but also depend on the health of the liver. How when you radiate, you try it's like usually like SPRT, and like radiation oncologists can give a better response to this. But usually it's if it's SPRT, it's stereotactic body radiation therapy. It's really like a design and to target like that spot or that lesion. But however, the field might be affected and depend on the liver situation, cirrhotic and cirrhotic, and location, and as well as how much is the disease burden. So this is a question I would say individualized based on the case by case.
If the cancer showed no targetable markers before liver transplant, can the cancer potentially return with targetable mutations after the transplant?
It can, and we saw it actually. We have, sometimes the recurrence have a different molecular profiling. Even sometimes the cancer itself, why in the first line, second line, third line, you see some selection, clonality selection of the cancer cells. So basically they kill the cells that's sensitive, and you have cells that is resistant to whatever treatment, and these cells that develop a molecular profiling slightly different. It's not the big percentage, but there is clonality selection of these cancer cells, and these cancer cells usually you see some differences. We saw cases that is PD-L1 positive become negative, and vice versa. Patient HER2 negative and become positive, and sometimes positive become negative. It's dependent.
In your experience, if a patient has had an allergy or allergic reaction to durvalumab, would CAR T therapy still be an option?
Yeah, allergic reaction, I would assume like, you have immunotherapy adverse event. That's what I assume the question is, right?
Yes, they put brain toxicity in parentheses.
Yeah, this is might be what you call it, like encephalitis for which is itis of immunotherapy. That's usually like it's not the most common one for immunotherapy, but it can happen. Does not exclude from the T cell therapy, but those patients actually who have immunotherapy toxicity that's significant, we are cautious about subsequent or immunotherapy related treatment, but does not exclude them. But I think we have to be cautious about that.
How do you judge the cancer is gone before you remove the liver?
Well, there is multiple modality we do that. We do scans, MRI, CT scan, and sometimes if we suspecting anything outside the liver, we do a PET CT scan. If there's suspicious for certain lymph node or lesions, we biopsy that lymph node or lesion. Sometimes, if after transplantation, we use ctDNA, which I publish on this actually, circulating tumor DNA. We just publish in a multi-center study with colleagues. Just like last month on post-transplantation utility of ctDNA. And also there's markers, CA19-9 and all that. So just to make sure that, you are clean after transplantation, there's, images, markers, ctDNA, this is taken in context of being positive before transplantation. So it have to be some relevance to it before transplantation, so you can for sure tell this is the right markers and this is the right answer for this. But generally, scans is the way to go, and this is the standard of care.
I have had a couple of questions come in regarding KRAS mutations, and if you have any insight on any targeted therapy options or anything coming down the pipeline with regards to clinical trials.
Yeah, KRAS has become as actually an interesting target, and there is multiple drugs have been actually been tested, and for example, I can actually we learn from KRAS from the pancreatic cancer, where it is actually it's a 90 to 95% of the patients have KRAS, and we thought that this is basically a mutation, and this is a poor prognostic factors. It's an oncogene. We never thought it as a target on pancreatic cancer. And then nowadays we have the KRAS is like a different subtype, KRAS G12C, G12D, and all those, and V. And it's vary in the presence on this, depend on the organ and depend on the percentage of this subtype. So there is ongoing clinical trials on using KRAS, and sometimes the medication can be agnostic. If you have KRAS with G12C, you can use it for this cancer, and maybe agnostically you can expand it. And that's why clinical trial is the answer for those patients.
Does a HER2 patient have to progress on HER2 targeted therapy before qualifying for the HER2 CAR-T trial?
Usually it's dependent on the protocol, but I think for most cases, they would like a patient to have an FDA-approved HER2 targeted therapy because it showed to have a good response. But it's dependent on the protocol. Some protocols, maybe they started like immediately after chemotherapy. Some protocol, they wanted to progress. So I would say like it's a protocol specific. But I would assume that most they wanted to be refracted to HER2 to be eligible for them. So to give you the best chance of those. But the protocol specific, I will answer.
We at the foundation often interact with a variety of patients of all ages, and someone is asking if you have your opinion on whether or not this particular type of cancer is rising in young adults in their 30s.
You mean it can occur in the adult in the 30s?
Do you see it? No, I think it's more like, have you seen an increase in diagnosis for people who are in their 30s or young adults?
Unfortunately, I saw some patients in the 30s and 40s. I can't tell based on like what we see in one center, like the numbers increasing. But we saw patients actually, and in the young patient population. Is it a trend, or is it like something that is going on as far as beyond the genetic component? It's hard to tell. But there is we saw.
Oh, I think, sorry, I missed hearing you. I don't know if everyone else did, but if you could just repeat the last statement.
100%.
Can you hear me?
I can hear you now, yes.
I didn't hear that last one.
Just your last statement would be great about the young adults.
Yes. So yes, we saw it in the young patient population and in the 30 and 40, and actually now I have a patient, she is in the 25 years old, 25, 26, unfortunate young lady with that age. So yeah, we saw it. I don't know if this trend is increasing, but we saw it, and there's some data, but not the strongest data like as far as compared to what we see in colon cancer and youth. There was a big trend in colon cancer. Is that true for cholangio or pancreatic cancer? We saw it, and I don't know if this is the trend, but the data is not strong to say that.
Okay, thank you. Do you use the same pre-transplant protocol for intrahepatic as with perihilar cholangiocarcinoma?
So yes, we have a protocols for each indication. For example, we have a protocol for HCC, we have a protocol for perihilar, for intrahepatic, and we have a protocol for stage 4 colon cancer with liver metastasis only to transplant those patients. So institutional protocol is actually like a specific for each institution, but in general, the trend is to have a good selection for patients for transplant that will have lack of evidence of cancer outside the liver.
When multiple targetable mutations exist, does it make sense to use one immunotherapy drug at a time to target the tumor, or is simultaneous immunotherapy advisable?
So when we see a targeted therapy and immunotherapy, is that, the answer, the question is to use, when there is multiple, I think this is a good question and it came about multiple times. How you sequence your treatment, which one you use first, which you use second. And I think this is the data. There's no head-to-head comparison to tell you like, oh, we compared this one with this mutation. Some mutations exclusive, and some mutations actually, if there's immunotherapy and targeted therapy, you have a good option there. But I think in situation like this, you wanna. I would say individualize. Sometimes, starting with immunotherapy, I give you the option of having a component. And I assume immunotherapy here is immunotherapy combination with chemotherapy. So that's versus you want to like start with the target therapy. So I would say like there's no data to compare head-to-head comparison, but it's a good problem to have when you have option to do immunotherapy, targeted therapy, and maybe chemotherapy combo later on.
Okay. There's a question regarding adaptive cell therapy and if it's available for patients with FGFR mutations.
I'm not quite sure if that, but this is a good question. You can double check. Not to be so my knowledge.
Okay, thank you. Do you have any experience with tumor infiltrating lymphocyte therapy and its efficacy on reduction of tumor size?
Not personally. There's scattered data, and also the data have been used for other cancers, and there was like some good response for solid tumors. But I don't have personally like our protocol in our institution.
Do you know, or your experience with pembrolizumab is it shown to be more effective than durvalumab? And does immunotherapy not target peritoneal metastasis?
Well, I think you're referring cross-trial comparison between the Bembro and Dorva in combination with Gemcis. I think there is the protocol for those is slightly different, where Gemcis for 8 cycle, then Dorva alone, and versus Gemcis with Bembro, and then continue with Bembro Gem. I think this is it's hard to say like it's head-to-head because there's no data like comparing head-to-head comparison. There's some retrospective, and I think there's some data even we looked at it in our institution, but I would say like it's not the strongest to say one drug is better than others. The concept is using immunotherapy with chemotherapy is the way to go. So I don't think there is strong data to say one is better than others. Both good options, I would say.
Okay. Can you share a little bit about living donor transplants?
Well, a living donor transplant, some centers, they are heavy on living donor transplant. Some centers are heavy on deceased donor transplant. And living donor transplant is that when you have the match, the surgery become an elective surgery. Like you don't have to, be listed and waiting for the liver. And, like this liver can come in at any moment when you have like higher in the list. Living donor transplant, you have your candidate, can be a family, friend, somebody who's matched, and the transplant center will decide on that after doing the appropriate testing. But this is becoming more elective surgery. You have like the donors, who's somebody walking with you to the transplant centers, and you are they test if you are the best match, and they do test for both the donor and the recipient, and make sure this is the best option for both. And this is usually become an elective surgery where they go, okay, this is the date that you're going to come in, and we're going to have the transplant, happening on that day. Versus deceased donor, it's a life gift from somebody who's signed to donate their organs to help other patients, where it could be happening at any time, at any moment. And there's a list for those patients who are going to get liver first based on criteria, UNOS criteria.
Okay. Are any of the options that you talked about boosting a patient's own immune system?
Yeah, I think the question is a good question, and this is like related how we boost immune system or maybe change the immune system. I would assume while in immunotherapy, if I get the question right, is that talking about if somebody in immunotherapy and combination and how we make the immune system even stronger. Some data have shown that is like changing the microenvironment of the cancer might increase the immunogenicity of the cancer. For example, if you do certain procedure like Y90, or you use like SPRT radiation to a certain spot, which is the largest spot, or sometimes the spot outside the liver, which is a metastatic spot. Sometimes there's episcopal effect can happen. You spill the antigens, and these lymphocytes become more educated and like become knowing more or become more excited about targeting the cancer. Basically, increase immunogenicity of the cancer by spilling more tumor-associated antigen, and the T cell will become more aware of this cancer that's been hidden. But now I think this can be what you call it an option for those patients if they are eligible for radiation or Y9.
Do you know if any information can be obtained from carcinoma cells present in ascites or pleural fluid?
As far as diagnosis or as far as obtaining the cells?
I think in general, maybe regarding treatment or even like additional biomarkers, things like that.
Yeah, I think the carcinomatosis can be an option or a site for biopsy. The cytology from paracentesis usually get cells, but this was like really low in number. If this is the only site of cancer and you're not able to, it might give you some cytology, but I don't think it give you to run the full molecular profiling. Some template and some providers or platform can do cytology and can do some evaluation of molecular profiling from cells that is scattered, or cytology, if you will. But other not. So I'd say depend on the yield and depend on the platform that you use to do molecular profiling or diagnosis.
Can you share any information on radiotherapy and how and when you applied this previous to liver transplant and cholangiocarcinoma?
So it's depends on the center. I know radiation therapy can be an option to treat or maybe bridge patient to transplantation. And sometimes, the local regional therapy, the Y90, the ablation, it can help more local control. Radiation therapy can have also more of a control in certain spots in a hope that to control the disease. But it's also depend on the center and depend on the transplant surgeon. So this is going to be a good discussion for the tumor board because sometimes radiation can complicate the transplant and depend on the size of the lesion radiated, the dose of radiation, the location of radiation, and the timing of radiation considering the transplant. So this is, I would say like center by center or transplant surgeon protocols might dictate what type of radiation, and each center have they have their own protocol for local regional therapy or radiation therapy for transplantation.
Is it possible for external radiation with immunotherapy to become synergistic?
I don't know if synergistic is the right word, but maybe increase immunogenicity and improve outcome because you change the microenvironment. Synergistic is like when you get more than additive. So it might be in some cases, but I would not say this is the standard because sometimes you get just more mileage for the immunotherapy just by doing radiation in some cases.
Okay, perfect. I know that we are at time and I want to respect your time. So thank you so much for your presentation and for fielding all of these questions. Thank you everyone for being tuned into our webinar today. We really appreciate it. So thank you again.
Thank you for having me and best of luck. Have a good day.